Hi. Good afternoon, everybody. My name is Souparno Bhattacharya. I am part of the Boston Consulting Group, and I work in their healthcare practice area. I'm a scientist by training, and a lot of our clients in BCG is focused on oncology. And I just want to take this opportunity to thank the organizers, the Project DataSphere, for giving me personally and BCG the opportunity to be part of these discussions. And I'm really looking forward to having our closeout panel to come here. John, Gary, and Bill. Gentlemen, welcome. Wow, we had really amazing discussions so far. Maybe if I can, John and Gary, we already have sort of like introduced you. Maybe Bill, if you can just introduce yourself quickly.
Certainly. First, thank everybody for allowing me to be here. My name is Bill Chambers. I have been a cancer researcher or administrator for quite some time. I'm a tumor immunologist by training. I spent most of my career running labs in Pittsburgh. I was the associate director for basic research at the cancer center there, and then deputy director in the cancer center for a while. Then I moved to the American Cancer Society and was the senior vice president for extramural research. So I ran all of the research and training programs and responsible for strategic planning and implementation of all the programs. And I have retired a couple of years ago, and now I'm serving as an advisor or consultant to medical foundations. I've been working with Project DataSphere for a couple of years, and also some family foundations, trying to help them decide on what are good uses of their money for investing in research. So thanks again for letting me be here. That's great.
Okay. So we have had 3 panel discussions so far, and from very different stakeholders. We heard from nonprofits, we from pharma and corporates. We also heard from educational institutes. Maybe if you can just 10 seconds to kind of reflect on these discussions and kind of discuss what resonated with you, maybe 2 or 3 points, what would that be? Maybe we'll start with Bill.
Sure. So there was quite a lot to unpack in all of this, but there were clearly some themes that emerged again and again. And I'm going to use the right word, I think, that I heard and put it in parentheses, and that's thoughtful data acquisition and use. And I thought that was quite a common theme that came forward. And then partnerships and the benefits from the partnerships and some of the challenges around those. And I'm a great fan of that. We spent quite a lot of time developing different types of partnerships when I was at ACS. And the third one is really 3 words, and that's access, access, access. We heard that talked about in a variety of different ways, and things that resonated with me were thinking about that balance between trust and effective use of the funds that you have, but really access and trust came forward again and again. So I think we're probably going to talk some more about that as we go along through this session.
Gary?
So first of all, it was really it's a wonderful conversation, and learned a lot. I had 2 really important takeaways. One was about data, because I love data and live in data. There needs to be a collaboration between all of these tremendous data resources out there and minority communities. Minority communities are sort of the end of the pipeline, and you need to connect minority communities to the data set, as opposed to building these standalone data sets in which you bring the ideas to the minority community in a passive way and don't engage them. The trust issues for sure, but we also have to build businesses and communities in minority communities. And so my strongest advice to all of these wonderful data holders out there is that trying to reach out to minority communities, in this case for clinical trials, where you're going to make them passive, a part of the process, is the wrong way to think about it. The way to think about it is to build networks with them so that they're your trusted voices in community. They build resources, and even more importantly, they learn a lot about the science and generalize it, which leads me to my second point. This is the disinformation. Everybody in this room is on the internet, doing webs, and many of you have got social media. We need to build a huge cancer social media component that brings us all together so that, because the secret of social media is the broad network and to help each other learn how to translate that data down to the American public. If COVID taught us anything, is that we cannot leave the community out of the conversation, because all kinds of bad stuff happens when they don't understand the science. And so there's an opportunity for us all to collaborate. It's pre-competitive, you know, and we can all work together, but we should have a cancer social media network on all of these platforms in which we've disaggregated the information and get it in a way that the American public can actually use it. I think that would be incredibly important.
John?
All right, it's hard to follow up those two. Let me see if I had anything else in my notes. Hang on one second. All right, there were a couple things that I think I want to just build on, which is how do we think about building those communities up that can then be, you know, create that trusted environment that is a way to interpret the information that's coming into that ecosystem, right? Pushing in the staffing and partnering with groups in the community to identify those missing needs, whether it's coordinators, patient navigators, genetic counselors, analytics personnel. How can we get there from here? We know how to train people, and we know we have needs. And some of the work that you've started already, I think, Dr. Puckrein, is really directionally one of the things we need to figure out how to amplify and to accelerate. You know, I think that this question about access is a critical one, and those barriers are not immediately obvious, because we've heard about some barriers that we thought might have been obvious, and they're not always the only thing keeping us from getting there. So, you know, how can we figure that out? And I think it's really by having people from different communities come and tell us, well, this isn't working because, right? Because there's only so much that any one person can know. And it really takes being on the ground and in the space and having the right cultural context to say, this is the way to move forward. So I think understanding how to get the resources in the cultural context is a really critical part of all of this. There was one other thing that kind of struck me, and it was a comment from our colleague at SAS about how models get developed and they're continuously evolving, and that helps work through bias in the models so that you get a better model that has less bias as things move forward. And that's kind of at complete odds with the way regulated development of things goes, right? You need to put a stake in the ground and say, this is good enough, you know, for now, and it gets approved, and the impetus and the timescale for change of that model that was approved is the different kind of problem, and one that doesn't fit the continuous model evolution. And it's something I think is just from a perspective of what I've been working on at Project Datasphere for a while, something that I would really like to explore also. So,
Thank you. Yeah, one of the things that resonated with me a lot about, I think multiple panelists mentioned this, like workforce development. Like, people like to get information from somebody they trust. So when you are like going to, you know, a community with racial minorities, you probably need to have somebody to relay that information who looks like them. And it can be social influencers, like Bill mentioned. No, I think Gary mentioned, in Instagram or in social media, or it can be your local pharmacist who knows you for a long time. So I think that's a vital piece of information that we need to keep in mind if you're talking about equity and access. I think Bill mentioned about partnerships. Both of you have a lot of experience of developing partnerships. So maybe if you can just give us some ideas, like different partnership models, and what are your learnings? What are the key pain points that you have definitely come across quite a lot? Maybe I'll start with John.
I think it's been brought up on some of the panels that defining the scope of the working partnership is really important, so that people come to the table with either a data asset or a workflow or some kind of tool, and they understand that it's going to be used within that scope, because navigating through the legal and intellectual property concerns often gets very hairy, and without a well-defined scope, I think it's very hard to navigate through those kind of challenges. So that's one thing that I think is really helpful. I think the other piece is really agreeing that the problem is more important than any, working toward the solution to the problem is really the goal. Yeah.
Gary?
The problem is large, and I don't think any organization can do it on their own. And there are wonderful companies out there, and I'm going to take clinical trials as an example, who try to build clinical trial systems on their own, and it doesn't work because it's going to take a very, very deep collaboration in order to make them work. We do a lot of work with federally qualified health clinics. And so when we're talking to the Native American community or the Hmong community that doesn't have a written language, or a FQHC that's working with people who are homeless, all of those are very, very different kinds of communities. And in order to bring those communities into clinical trials, you have to have the trusted voices in those communities and bring the data with you in order to help them understand the value of participating in a clinical trials. And so the way I look at this, I started that social media component where we can start to educate the American people about science generally, about clinical trials specifically, because our failure to help the public understand what it is we're trying to do and why we're asking them to participate will only make the task much harder. And this is a resource that's available to us all. In fact, I look at it and I say, everybody talks about all these algorithms that create all of these hate groups. Why can't we create algorithms that respond to that, so that when people are pushing out this information, the algorithms also push good science and good information? I mean, that's not difficult to do. And I think we can all collaborate and build things like that together. This is a community activity where we have to build infrastructure in communities that were left outside of the science for generations. And now we want to bring them in. And I think the way we have to do that is we have to work together and build collaborations to make it happen.
Bill?
Okay, a couple of things. So cancer is a pretty personal disease, and there's probably not anybody in here who hasn't been affected by this or their family, for sure. So you're starting from a place where there's commonality and purpose, and then that's a good place to start from. But you need to understand the people that you're trying to partner with. And for me, working in academia and the nonprofit, I had a pretty good understanding of the drivers, and having a leadership role in a cancer center, understood the drivers for the faculty and for the institution and also for the nonprofit. So really being open about what the issues are there and understanding about that, and trying to find a place where both partners could get what they needed. And most of the time that's possible. Sometimes you'd find things that you couldn't get around. But But once again, back to another element of trust that you've raised in another setting here. But I think those things were really important for partnerships. And if you want to add anything to that, John, I know you've spent more time with startups and in pharma, that kind of thing. We've done that also. But
Feel free.
I mean, I think it starts with conversations like this, right?
That's how we started.
Yeah, exactly. But I feel like we just need to identify one thing that kind of unifies us, and what could we do, right? Can we, like, even though I've talked to almost every panelist here extensively before this meeting, I learned more today about the programs that each person has going on than I had known before. So how can we continue that kind of conversation and build momentum and find ways to say, okay, we have this great benchmarking tool. We have these stories, these patient stories, for example. Now we're coming in with an intervention with this earlier screening technology. Is that going to move the needle? How can we assess these things and say this made a difference? Because we believe that it should. We have good motivation and understanding for what it is. Now let's make sure that we can, in the future, look back and say, that made a difference. I think that that's the kind of conversation I want us to have from this point, here. And it's really about trust and hearing, what we need, who's not here. One group that's not here, we really need to do a better job of working with patient advocates. I think that's something that's really important, that voice. It's something that I've started to better understand and speak with more patient advocates, but it's certainly something that would provide a different point of view on these issues, right? So how can we do these things?
I would just jump in on the data side because, I've lived with this data. We've actually mapped cancer down to the zip code level. And I walked away with really a couple of takeaways. First of all, many cancers have a geographical feature to it. I don't know, if you look at Kentucky, for example, it looks like ground zero for lung cancer in the United States. Probably West Virginia and Kentucky are probably ground zero for lung cancer. I have no idea why it is, but you go look at the data, and there it is. And there are other cancers that present that way. So cancers have a geographical face to it. The other thing that I find really interesting is that it's highly predictive. You can actually, down at the zip code level, predict how many people are going to get diagnosed with cancer in a year. It's crazy, but if you look at the data, it says that cancer is highly predictive. So if it's predictive, it means that there's some superstructure, some understructure there that we should know about and be able to control. And so part of it, when I look at the data and I look at our growing capacity, what we try to talk about at the National Minority Quality Forum is, how do we control cancer? How do we get smart enough so that we are controlling cancer as opposed to cancer controlling us? And I listened to all this wonderful data from Kroger and Change Healthcare. The data is there. We could do that any moment we woke up in the morning and we decided that we were going to predict and control cancer down at the community level. Job done. It is us to make the decision. I was in France last week. And the Ministry of France is developing a nationwide database. Every Frenchman, his data is now being compiled in a database. The same meeting, India is doing the same thing. They have less capacity than we do, but they're taking everybody and they're building a national data set, all of which will allow them to make it available to research. That's the first thing I ask, because in this country, getting access to data is an art form in its own right. So my first question was, will researchers have access to the data? And the answer is yes. And so I think we're sitting at this moment where we have some very critical decisions to make. And the question I would put to you is, would you like to control cancer? I mean, would you like to wake up in the morning and say, hey, this is the job that we're working on? I think the data is there. I've looked at it enough to say, and I ask everybody to go back and look at their own data. Go back a couple of years and see if it's not predictive. See if you can't look at the zip code and predict the type of cancer. It's even crazier than that. And I think you're going to find, hey, you could do that tomorrow.
Interesting. Maybe, John, this is a good segue to my next question. If you look at like Project DataSphere's tagline, being a catalyst for health equity access is one of them that you can find in the title. Based on today's discussion and the challenges, what do you think are one or two things that Project DataSphere can do to kind of move the needle, to increase health equity, increase access to clinical trials and medicines, etc.?
I think that the most important thing is really to hear from people who are facing these gaps in their communities, in the care they provide, and then trying to find ways to partner to provide support and services. I think that's, Project DataSphere is got this snappy tagline as a convener, a collaborator, and a catalyst. So we're here, we're having this meeting, success, check. Collaboration, we've built some, we want to help build more, but being a catalyst, it really means trying to get under the hood and understand what those internal barriers to change are and systematically reduce them, right? That's I think what we need to do is identify where we can productively collaborate and then get in under the hood and take those barriers out. And that's really a conversation that requires leadership, it requires multiple perspectives, and it requires having, a singular focus on making a change.
Gary, do you want to comment on that?
I'm going to mention a project that we're working on in Flint, Michigan. In Flint, Michigan, because of the water, they think they have a cancer cluster there. And so we were approached by the White House as part of the Cancer Moonshot to begin to do some work in Flint, Michigan to try to see, number one, do they in fact have a cancer cluster there, but even more importantly, to begin to put a demonstration project together in Flint, Michigan to try to address the cancer. I welcome everybody in the room to take a look at Flint, Michigan. I always believe you ought to take a point, one place in the world, one place on the map where you start to make a difference and try to figure out, so why is this particular place broken? Why is it like it is, and what can we do collaboratively together to make it better? And so we call it the Cancer Stage Shifting Initiative. I think I mentioned that earlier. But that's where you bring the data. That's where you bring the access issue. That's where you bring the training. That's where you concentrate your effort in one place and demonstrate to the rest of the community that you can actually do this. We can actually fix something. And so for me, I look at that particular initiative, and it's a broad collaboration. There are lots of people that are beginning to put their arms around it. And there are other cancer clusters. For those in Louisiana, you got your cancer clusters in Hawaii. You got one here in North Carolina. So there are a bunch of them. But we should try to figure out one place where we can get something done and show that, hey, we can actually do this and work together. So that's what I would put on the table.
Thank you. I think we're at time, but maybe, Bill, if any closing remarks, like to just...
You might have some questions.
Yeah, or we can...
I have plenty.
Yeah, we can do a quick, maybe couple of questions. Yes, sir.
Hi, John Williams with the President's Cancer Panel. Dr. Puckrein, what a wonderful suggestion about communications, especially from our perspective when we just issued a report about how to close the gaps in cancer screening for our nation. And one of the key opportunities was communication. How do we align and provide better communications that reach all communities, which is part of the problem that we struggle with. And we thought about the different communication modalities, whether it's written, online format, but I just love the idea of creating a social media, cancer-related social media entity that would then have critical mass to bring in influencers, to share different messages, but good messages. And it is a phenomenal idea. And it's also the reason why these roundtable discussions and models allow people to share those ideas and get together and connect the dots to complete them. So I think it's an incredible opportunity if there's a way to do it, and you might have like minds in this room to help accomplish that or begin it.
I think we have to take over the social media space. We have to stop apologizing and take it over. The challenge is, and I love scientists and the work that they do, but they talk to each other, right? I mean, and you've left the folks behind, and so they're down there believing in goblins and witches and God knows what all, right? And then you come with things that can help them, and they don't have a clue what the hell you're talking about because somebody's already, and I love that dominant logic. Somebody mentioned dominant logic, and I thought you were right on. That's exactly what we've permitted. And so we got to go claim that space. And so I think one of the smartest things that would come out of here to do is to build that collaboration and take over TikTok and Twitter and any Facebook, God knows what else is out there, and begin to give information to people that they can actually use and improve the quality of their life. And I think that's what social media should be about, as opposed to all of the Kim Kardashian stuff that we seem to be engaged in.
So,
maybe last question.
This is a great discussion. I'm an endocrinologist at Duke, and I actually run my own podcast. It's a medical podcast on toxicities from cancer drugs. So I can tell you from personal experience about media influencing in the space that, number one, when you have academic physicians or you have folks that are experts in the field, they need time to do this, number one. Two, they need the money to support. I support my own podcast, but you do need time. You need it's easy to say we want influencers, but when you have these people on board, you really need to buy their time, their effort, support them financially, because we really tried to get pharma to support this, and there's so many layers of decision-making and red tape that goes into it that I finally gave up. I said, you know what, I'm going to do this on my own. It's an important thing. We're just going to do it. But these are some things to consider when we really want to get communication. You want influencers, you want people to speak about this, and you want people who know what they're doing and talking about it to open up. You need to support that. So I just want to put that out there, that it almost always boils down to dollar signs, and that's where we seem to miss out the message. People are ready to do this. It's where we bring in that support.
So for both the comments or questions, when we're talking about a collaborative innovation network, but maybe some sort of different permutation of that, but you can drive innovation through that, but you were talking about a more open forum that's going to be attractive to people beyond just in a particular discipline. But it's not hard to tie opportunities for grants, that kind of thing, that would be attractive to the academics in that. And in point of fact, the ACS has something like that, but you're talking about something on a broader scale, which I'm 100% on board with that. I think that's a great idea. And the World Economic Forum operates that way, and then there's some. I'm blanking on some of the other examples, but there are a number of examples for modeling about how to set that up and how to organize and run that type of platform.
Caitlin, do you have time for more questions? Or
John, you're the one who has the time.
Yeah, I think we could probably do two more quick questions, but they have to be kind of quick. Sorry.
Maybe start with the gentleman at the front.
Yeah, so when you think about it, health disparities is generational. And to deal with something that is generational, you have to deal with the upcoming generations. Meaning if you want something to change regarding access, equity when it comes to cancer, cancer research, cancer trials, young people cannot be left out of this conversation. And when I say young people, I'm talking about people that have, very young people, young school, adolescents. And again, there must be a way to engage parents in all of this. We dealt with this with COVID when we tried to vaccinate young children. And parents, some of them wanted to get vaccinated, but they didn't want it for their children. And so this became a serious obstacle for us And the idea, we knew that this was a population that was going to be very difficult. And so what I had to do is I had to go to PTO meetings in order to engage parents. We did that, and it worked for us.
Maybe, yes.
Question or comment? I just want to ask Dr. Puckrein, in reference to zip code driven data, how will we have accessibility to such? Because when we're on the ground, as I am the Gold Community Engagement Coordinator for Shaw University, so being on the ground and trying to build trust or to build relationships in the community, I can speak more intelligently as to what is causing or what has created or what the trends have been in a certain area. But how will we have accessibility to such that I can go out and speak and build relationships?
So first, I think we've already made available some of that data to your program. And so we just need to go back and check and make sure that it's there. But we also have built a site. It's called shiftcancer.org, where we're taking all of the maps that we've created and putting them online. So you can get down to the zip code level. And by the way, we also do it by congressional districts because members of Congress need to know what's actually happening in their district, so that because we look at them as the trustee of the healthcare system, so they need to be informed. But all of that will be online in as part of our stage shifting program.
Maybe one last question. Yes.
Thank you. This has been a fascinating day. I'm a little bit surprised that after 4 panels, all kind of focused on some solutions to addressing health disparities, we haven't heard once mention of universal health care. And I just really firmly believe that until, groups like this start to talk about, we've heard, access to insurance dictates the type of cancer care you get. And unless we as a society start to believe that every American, it's a human right, and to cover every American life, then Dr. Lichtenfeld, I think, no, we're not going to make any progress, and we're going to be talking about health disparities for the next 20 years. Dr. Puckrein, you mentioned France and India doing national databases, and we can do it too. We can't. We don't have a universal health care. We don't have a single database where all of our records as a nation would be. We have so many people out of our system. So I could engage the panel, or I could just leave that as a final thought, that I just think it's an important topic. And, I wonder when rooms like this that talk about health disparities are going to actually talk about universal health care.
So I'm going to support the notion with a discordant note, which is, yes, we ought to have universal health care. I'm not one who believes in government universal health care because government then becomes the monopoly purchaser, and they have a way of becoming the object instead of the patient. So I think it has to be mitigated through plans, obviously with good data to understand that we're getting great outcomes for patients. But this is my personal preference. I live in the Medicare and Medicaid data. I don't know anybody in their right mind would want to be on the Medicaid program, and I understand why they're there. And one-third of the American population, 90 million Americans are on Medicaid, 1.5 million are Medicaid eligible. So we've got a large percentage of our population, 45% of the American population is either on Medicaid or Medicare. And I'm just not going to sit here and tell you that that's the best care that's out there. I'm just not going to say that to you. There's some real thought that has to go into how do we provide quality care to all Americans. We have the capacity. It's $2 trillion. That's what we spend every year on health care. It's $2 trillion. In my land, that's a lot of money. I think we can figure out how to use $2 trillion to get quality care to every American. So it's my personal sort of.
Thank you, Gary.
Yeah.
Looks like we're at time. Want to thank the panelists for their insights and for a stimulating discussion here.